The Building Hope Scholarship Program was launched in July of 2017. It was created to ensure that no Summit County resident was denied access to care due to a financial barrier. Since the program's inception, the program has provided 781 unique scholarships and paid for over $300,000 worth of care for Summit County residents alone. The program was designed in a way to always be a pair of last resort, with insurance navigation integrated into the screening process. Our staff and issuing sites undergo training to ensure that whenever possible, people are connected to mental health care through an established payer source first. To date, Summit County experiences among the highest insurance premiums in the nation. Despite having a perfectly good payer source and paying some of the highest premiums in the nation, 54% of scholarship recipients, of our Building Hope Scholarship recipients, have insurance and cannot utilize their insurance for a myriad of baffling reasons.
According to data from HCPF, substance use disorders and mood disorders are among the top 10 conditions for associated medical costs. Prioritizing and successfully treating these conditions will likely result in substantial reductions in medical costs. Medical cost savings could then be used to address other behavioral health priorities.
Substance use disorders, it doesn't have any targeted populations. It doesn't have any people that it likes to favor, any social economic classes. We see individuals from all corners of our communities, and it'll take any opportunity it can to impact people.
The bottom line to the issues is money. We got a notification last week saying that one of the Medicaid rates that we work for is lowering our rates by 20% in January. 20% is a lot of money, especially when you already work for really low rates.
And the hard part is keeping good therapists as it is already a struggle. It is. It's an unfortunate reality. And when we had to sit in front of these 20 therapists, these therapists that people are bragging about, our main assessor is to the point where the federal probation will only utilize him for their assessments. And they're looking at us going, if this happens in January, Casey, we don't know what we're going to do. And that's a tough thing to swallow.
And we've had a lot of families who are struggling because they're working with somebody who has the dual diagnosis. And the biggest thing is that when you've got a dual diagnosis, everybody says, nope, you got to go over there and you got to go over there. So the fractured system is our biggest concern because families don't know where to go and they're frustrated on that.
MHCD dropped him, which is the biggest contradiction ever. How do you drop somebody who's gravely disabled? How do you deny someone services like that? He also was denied services because when he did come out of Pueblo, the intake coordinator at MHCD told me that he can't get services because they're waiting on what the pending charges are from his probation officer. He just came out of the state hospital, and you are waiting on what the charges are to get services. So we're leaving out a huge vulnerable population that we're not treating, which is the gravely disabled and the severely mentally disabled. It takes 4 to 6 weeks just to get an intake.
I want to just go back to this. Brief hospitalizations are generally not helpful. My son has been in and out of M1 holds numerous times, and they really don't work. And there is in the statute the ability for somebody to stay longer, but in the real world it just doesn't happen.
Even now, as I speak, 4 days ago, my son was released after his 5th M1 hold by Swedish Hospital, who failed to follow the law and released him even with the specific details from Mental Health Center of Denver's crisis team that they needed to find my son long-term treatment and not release him, as this was his 5th hold in 7 weeks with nearly fatal alcohol poisoning to drown out the voices from his schizophrenia.
There's a lot of people. I was 10 years as a culinary instructor for the Lookout Mountain Youth Service Center in Golden, and there were prescriptions given to some of those juveniles that really benefited them, But in many cases, it was kind of also, I thought, used as a behavioral management tool for security reasons in some cases from my observation.
You know, and I'm not ashamed to say it. I mean, I've been clean and sober for 18 years, so I'm very familiar with that lifestyle. And I work with a lot of jail inmates as a result of that, going in and carrying the message, you know, of hope. I'm involved in a prison ministry in Sterling. We spend every other Saturday in maximum lockdown talking with men. And you talk about some stuff that's not how bad, and, you know, I want to hear your stories. As it comes down to this, and what I found is, you know, people just they want somebody to listen to them.
I have a now 16-year-old son that was adopted from foster care. He was born cocaine positive. He came into my home at about age 6 months, and his whole life has been a series of aggressive outbursts, antipsychotics, and continual fighting to get services for what he needs. He currently is in a residential facility where for the first time ever he's making progress. For the first time ever he's learning to deal with the voices. Because he started displaying symptoms as early as age 3, I don't know that I've ever known my son when he wasn't in psychosis or having delusions.
And it wasn't bad because the people were bad, the people that worked there. I thought it was a traumatic situation, both for the residents and for the workers. And I hope we never go back there again. And I decided then that I wanted to devote my life to keeping people out of institutions of all kinds, including jails, prisons, large institutions.
The perception is that once they're on the medications and the usage goes down and the craving stops, the problem is solved. But we know with addictions, prior to that, there's all kinds of lifestyle and family and employment and trust issues that come from that. So our concern is medication-assisted treatment is really turning into medication.
People in psychiatric emergencies and crisis suffered unnecessarily in unsafe places, sometimes for days, because psychiatric hospitalization was unavailable to them in their most desperate moments. This because there was only one psychiatric hospital, which we operated, but it was a mere 32 beds, and for the last 3 years, there was a wait list for a psychiatric hospital, a wait list. Staff had to make unimaginable decisions on an hourly basis. Who needs the bed the most? Is it the young boy who's actively suicidal? A teenage girl experiencing a first psychotic break? A young mother who's in a hospital ER and has been there for 2 days? It's untenable, and it had to change.